Hey everyone, welcome back to part 75 of our 100-part CPC exam series. Before we get into the weeds today, make sure to like, share, and subscribe to Decode Healthcare with Harshal. You know, it's wild, but evaluation and management coding is actually the #1 area for medical audit failures. Seriously, it's a huge deal. So today, we're taking a massive step toward getting you certified by completely bulletproofing your grasp on core EMM principles. Look, you absolutely have to master this stuff. E&M coding makes up a solid 10 to 15% of your entire CPC exam. These codes are all about capturing the cognitive heavy lifting of the provider. We're talking about the clinical reasoning, the anxiety of nailing down a diagnosis, the whole management planning process. To pass, you've got to know these modern guidelines inside and out. So let's simplify these core principles into a foolproof strategy you can actually use.
Okay, let's dive into this. For years, coders were kind of stuck in the old way under the 1995 or 1997 guidelines. You literally had to painstakingly count bullet points for the patient's history and physical exam just to figure out a code level. It was a headache. Thankfully, the 2026 way completely throws out that rigid bullet counting. I mean, sure, a medically appropriate history and exam are obviously still clinically required, but they no longer drive your leveling. Instead, the whole focus has shifted to what actually matters: medical decision-making, or MDM, or the total time spent on the exact date of the encounter. But hey, before you even think about time or MDM, you've got to establish patient status. This is the absolutely crucial first step to finding your correct code family, and it all comes down to the 3-year rule. So, a new patient is someone who hasn't received any professional services from the physician or another physician of the exact same specialty and subspecialty in the same group practice within the past 3 years. If they have been seen by that exact specialty in the group within 3 years, boom, they're an established patient. Mix these up and your entire claim instantly lands in the wrong code block. No way around it. Right, so once you know who the patient is, you need to know where they are. The setting dictates the exact code range you're going to apply. We've got distinct families for office and outpatient visits, hospital inpatient and observation care, the emergency department, nursing facilities, and consultations. Basically, just pinpoint that category first, and then you can apply the correct leveling method for that specific environment.
And this brilliantly illustrates the big fork in the road for your E&M strategy. Most categories actually let you choose whichever path results in a more advantageous code level, time or MDM. If you go with time, just remember it's the total provider time on the date of the encounter. That includes both face-to-face and non-face-to-face work, like charting on that specific day. But, and this is a big but, pay close attention to the exception. Emergency department codes, that 99281 through 99285 range, rely purely on MDM. Because emergencies are, well, unpredictable, time is just never a deciding factor for leveling ED codes. Now, if you aren't using time, you're relying on medical decision-making. MDM basically measures the cognitive work across 3 core elements. It's almost like a clinical puzzle. Element 1, the number and complexity of problems addressed. So what are the actual medical issues being evaluated? Element 2, the amount and complexity of data to be reviewed and analyzed. Think interpreting labs, imaging, maybe tracking down old records. And element 3, the risk of patient management. This evaluates the danger of treatments, stuff like prescription drug management or making decisions for major surgery.
Now, what's really interesting about this slide is how forgiving the scoring system can actually be. The AMA and CMS use what I like to call the rule of 2. Actually, scratch that. Think of it more like a best-of-3 series in sports. You don't need to hit the highest level in all 3 categories to score your code. To qualify for a given level of MDM, exactly 2 out of the 3 elements must meet or exceed that level's requirements. Basically, you get to drop your lowest score. So if your doctor handles high-complexity problems and higher risk, but barely looks at any data, you still score a high MDM. Pretty cool, right? And those 2 out of 3 elements will land you in one of 4 final MDM levels: straightforward, low, moderate, or high. Straightforward is for your minor self-limited problems. Low handles stable chronic illnesses. Moderate steps it up to exacerbations or prescription drug management. And high, well, that involves severe threats to life or major surgery decisions. But listen, beware of a massive exam trap here. Do not overlevel just based on how sick a patient looks. MDM reflects the documented provider work. If a doctor saves a life but documents it with a vague 1-sentence note, you cannot legally assume a higher level. If it isn't documented, it didn't happen. So the crucial point is really mastering these basics. Let's lock this visual cheat sheet in before test day. New versus established relies entirely on the 3-year exact specialty rule. Time leveling, total provider time on the exact date of the encounter. MDM, you gotta meet 2 out of the 3 core elements. And finally, the ED rule. Emergency department visits are leveled by MDM only, never by time. Honestly, just master these 4 pillars and you're gonna navigate the EM section with total confidence.
We've laid a really solid, critical foundation today, but it begs a massive question. What actually happens in an audit when a provider's total time qualifies for a low-level code, but their medical decision-making qualifies for a high-level code? I mean, which one legally protects you and which one gets you slapped with a fine? Up next in Part 76 is our MDM Deep Dive, where we'll analyze the complexities of the data, risk, and problems address tables to answer exactly that. Keep practicing those guidelines, keep asking why, and I'll see you in the next explainer.